Good morning and welcome to Issues That Matter. I'm your host, Robert Piccone, and today I'm joined by a guest co-host who I'm honored to have back, Noni Freeman.
Hi, Bob.
And we have a couple of guests on the show today that I'm sure is going to give us a great deal of information on something that is critically important. So let me welcome Dr. Rebecca Koala.
Thank you. Good to be back.
Rebecca, and also Bridget Franciosi,
Yes, nice to meet you.
who's a nurse practitioner, and they are with the Southern Maine Healthcare Palliative Care Team. And I will open with an opening question. What is, for those who have not seen previous shows, what is palliative care?
In 25 words or less.
It doesn't matter to me. Well, palliative care is a specialty in medicine that all the patients that we serve have a serious illness. So one that we know is chronic and progressive and likely to impair their quality of life. So palliative care is a specialty that focuses on helping a patient live as well as they can in the setting of that illness and knowing what to expect, having good pain and symptom management, and thinking through always keeping an eye on their quality of life. I guess that's kind of basically it.
Would there be anything you might want to add to that, Dr.
I think
Koala?
that's a good overview, yeah. Really focusing on the fact that these are people living with a chronic illness, but continuing to, live their lives and be active.
And I know we had some discussion before the show about the differences between palliative care and hospice care. In my mind, I see a lot of similarities. What are some of the differences?
So the way I describe it is that, all hospice care is palliative care in that it's all under the same kind of philosophy of care, which is a focus on quality of life, on symptom management for people who are facing a serious illness. Hospice care is for patients who are in the very last stages of their illness, in the last 6 months or so of life. And it's a more prescribed program of care that involves a team approach, keeping patients at their home, making sure they're comfortable, and providing them with a little extra support in the home to be able to live comfortably at the end of life.
Yeah.
One of the things that helps me distinguish between regular ongoing medical care and what's meant by palliative care is the idea of the regular ongoing medical care seems to be very interested in quantity of life and might be searching for all kinds of treatments and modalities, different ways to lengthen somebody's life. And sometimes I look at that as aggressive medical care, possibly. Surgeries, new medical treatments, medicines, and so forth. But with palliative care, my understanding is the real concern is for folks to be able to have the quality of life that makes life worth living. So it might mean that one's life is shorter in the end, but hopefully one's life is lived with as much joy and fulfillment as possible right up until, the very end. Does that make any sense?
I think that's a really good point. Also, when you think of all of the wonderful things we can do in medicine in terms of holding back a disease or addressing the problems that a disease causes, just because we can do certain things doesn't mean that that is right for that person. And so palliative care kind of builds in more of a discussion in terms of, yes, you have this problem in your heart. Yes, there is a major surgery that you could have to, fix your valve or whatever the problem is. But in the setting of all the other things you have and who you are as a person, is that something that you really value, a major surgery? Or are you more thinking, I don't want to go through all that, knowing that that's fraught with risks, depending on what age you are and what stage of life you're at, that maybe those things that we offer just because they're there and could be done doesn't mean that it's going to fit for you. And so palliative care oftentimes helps people figure that out. Is this something that I want to do? What are the burdens and benefits of all of the options that we have, which can be very overwhelming in medicine today? There's a lot that we can do. And so thinking through whether that really is going to help that person reach their goals, and fully understanding the ramifications of decisions is oftentimes how we help patients in, you know, the very busy, complicated world of medicine today.
And what might be some of the considerations that take place when you're trying to help a person make that determination?
Sometimes it's just what are some of the other conditions that they have. If we're focusing on one problem right now, what are some of the other conditions that they have that could feasibly be affected by those procedures or those treatments? So if you're facing a surgery and you have, for instance, dementia, sometimes having anesthesia could actually worsen your dementia to a point that you may be at a different baseline. Or everything is fraught with risks, and thinking, knowing going into a procedure, what possibly could happen? What are the good outcomes, and what are we worried about? So that you can make a decision based on having all the options, which, you know, can be pretty overwhelming sometimes. And that's when we need to involve families, because actually the patient who's not feeling well might not be able to put it all together. So working together as a team to really present those options in a rational way, and so that people have almost like an informed consent of what does this look like down the road? How do other patients that have this surgery that also have dementia or COPD or another chronic condition, how do they do over time? And giving them the best information, thinking through those things.
Well, speaking of dementia, a lot of us associate Alzheimer's with dementia, but I understand that there are some variations on the same theme. Want to tell us a little bit more about that, Dr. Kowalef?
Yeah, so Alzheimer's is certainly a name that's probably applied to most dementia out there because it's a familiar title, but dementia can be caused by a number of problems other than Alzheimer's, which is a specific illness that causes early onset dementia. Vascular dementia is something that we see a lot in patients who have heart disease, have had strokes, maybe have been smokers. Their vessels are just kind of tighter, and those really tiny vessels in the brain just can't get blood to all areas of the brain, so they get these really, really tiny, essentially little strokes that over time build up and have damaged the brain tissue such that now they're seeing signs of dementia. So that's a very common cause of dementia. And then there's dementia associated with Parkinson's and other, you know, more chronic illnesses that can progress to dementia symptoms.
And there's also senile dementia.
Well, senile dementia is, I think, a catch-all term for a lot of these types of dementias. So vascular dementia, Alzheimer's, if patients have Parkinson's and
I
they're
know my
older.
mother was diagnosed with senile dementia.
Yeah. Yeah, so that's I would say it's a catch-all term for a lot of different types of
Kind
dementia.
of like an umbrella.
Yeah.
There's many different causes but the reason why it kind of gets lumped all together is because the behaviors and problems that people develop, regardless of the cause, are kind of similar. Mm-hmm. So it's under an umbrella of dementia, and then I think there's multiple different things that can set the stage for a cognitive impairment that can look like Alzheimer's or vascular dementia or other things like Parkinson's, metabolic disorders. People with diabetes have an increased risk for vascular types of dementia. So there's lots of contributing factors, but they all kind of lead to a similar subset of symptoms that impair quality of life.
Now, I have multiple sclerosis, and I from what I understand, and I've understood this for a long time now, that multiple sclerosis can cause impairment cognitively.
Mm-hmm. It definitely can, yeah, and it's you know, everybody's course with MS, as with any type of dementia, is a little bit different, but certainly not all MS leads to dementia, but it's a possibility.
Might a person that has MS end up, deteriorating to the point where they become, they diagnose as having some form of dementia?
Certainly they could, and it's really a matter of, you know, how the whole picture of MS is progressing. So if the more physical symptoms are progressing such that sort of limits the length of life and they don't progress to the point of having cognitive deficits, then not everybody does. But it certainly is a possibility if given enough time and progression.
Thank you.
Well, let's talk about that. Let's talk about someone with a chronic, debilitating illness who also has dementia. Someone for whom you might want to talk about the possibility of using palliative care. How can palliative care help a person with dementia?
So I think it can help in a few different ways. For one, especially early on when we're first seeing signs of dementia, but the patient with early dementia is still able to have a conversation, I think palliative care can be really helpful in helping them figure out what quality of life means to them, what abilities are really important for them to be able to do for themselves, and to communicate that with their families, so that as patients progress in dementia and are less able to communicate, that the families have that baseline to really understand where this patient's at and what's important to them as they have to make decisions down the road. And then I think the other piece is to do some education with patients and families as what might be ahead. So we know, as Bridget said, just regardless of the type of dementia, dementia tends to progress in a fairly similar way and have similar kind of mileposts of progression that we can prepare patients and families for, so that they know what decisions might be coming, what pitfalls might be ahead. And then when those do happen, it doesn't feel quite so much like a crisis mode and they don't know what to do, that they really have some preparation and may have given some thought to what kind of decisions they'd like to make.
I really love this approach because it gives every one of us, if at some point we're in that position or we have someone that we really love who's in that position, like you've had in your family, Robert, sorry.
I'm not sensitive to that.
It gives the person, the patient, if you're involved with them early enough, who has dementia, the patient with dementia, it gives them an opportunity to really put out there how they want to live the rest of their lives, knowing that their life is really going to be impacted by this disease. So at some point, they're going to become much less maybe aware of their surroundings, much more forgetful, and they're not going to be really in that driver's seat the way they are at the beginning. So it's wonderful to know that there are people like yourselves who really want to help the rest of us with all of this planning. Okay, well, there's not much maybe we can do. We're not going to be able to stop this process, but we can help you make some decisions now as you approach going through the process. And then to do the same thing with family members. Talk with the family about what they can expect and what's going to go on. I can't tell you how many times I've heard from family members, we don't know what's going on. We wish we knew what was going on, and they get so angry with the medical establishment because they didn't know what was coming up. And so the family does the best they can. They kind of punt to make the best decisions possible, but they have such deep regrets.
Right.
Yeah. I think one thing that makes this all very tricky too is when a person receives a diagnosis of anything, they don't really understand the full ramifications of what that's going to be. And even when you receive a diagnosis of cancer, you don't really fully integrate the full meaning of that illness until you start to live with it for a time. Being human beings, accepting what is, accepting what you know, what you don't know, and families too. With dementia, it's important that you understand this is a terminal illness. This is going to progress over time, and you need to kind of come to a place of acceptance. And I think the other thing about dementia that's so important is caregivers really have a lot of work to do, preparing their own selves for what is going to be expected of them, what they are going to be seeing in their loved one, and that it could be a very long, protracted time, or there's going to be periods of ups and downs. And, understanding that dementia is a terminal illness, but it's not just memory loss, it's brain failure. You really have to think of it as a gradual brain failure. And so that person who you know their personhood and who they are, and you have this relationship, that person almost loses their personhood over time. But you're still, as a caregiver, a daughter, a spouse, a loved one, seeing that person as that person, but they're kind of moving into this other place. So it's very difficult. You hold them accountable for things that they don't have the brain to be accountable for anymore. And it happens gradually. I sit with patients and families of a dementia patient who has kind of crashed into home plate and comes into the hospital because our system doesn't support these people to take care of them at home well enough. They come into the hospital in crisis, and the son or daughter says, you know, they're really not that bad. They know me. Those kinds of things. And yet then when we start to unpack what's been happening at home, we see they really are in the advanced stages of dementia. And coming to an acceptance of what to expect, and then accepting when you're there, and figuring out how best to take care of ourselves as caregivers at the same time as meeting the needs of the person, is a very difficult dynamic. So thinking through, dementia is a terminal illness. Oftentimes when I sit with patients and families in the hospital, I say, you know, if your mom had cancer and you knew that there were no more cancer-targeted treatments that would help, you know, and her time was limited, you might feel differently about aggressively treating things. But with dementia, we have almost a different understanding that this could go on for a long time, and I don't want to not do something that might give them a chance, but knowing what to expect, what symptoms do constitute advanced dementia, final stages, and what is likely to give them the benefit that they're hoping for, but accepting that this is a terminal, debilitating illness that's not going to get better.
Bridget, you mentioned something about the symptoms of dementia, that it's not just memory loss. It's more involved than that. Could you put it in sort of layman's terms about the kinds of behaviors or symptoms or whatever one would expect to find in a person with dementia?
Sure. It's kind of, there's a lot of symptoms, but some of the ones that cause the most kind of social issues is like not wanting to bathe, and not wanting to, the steps, not knowing the next step. So you put a plate of food in front of someone with a severe cognitive impairment, they don't know to pick up the fork. And then if you put the fork in their hand, they may not know, what do I do with it next? And people get frustrated because people have been eating and feeding themselves for many years. And it's like, Mom, you know, there's your soup, you know, that kind of thing, but they don't know the next step. And so those kinds of sequencing things get very difficult. And a lot of times bathing, personal hygiene, those kinds of things. And then people become argumentative, you know, reminding them that they didn't, that they, you know, you remember, we did this day. Those kinds of things they can't follow. And then agitation can happen because they can't process what it is you're giving them, and that makes them feel kind of out of control. Those kinds of things. And I don't know if Rebecca has any other...
I would say sleep disturbance, so the day and night cycle gets messed up, so patients are awake at night, or they may be wandering at night, and then maybe sleeping all day. So, and you know, caregivers often have to go to work, or they're just on a more normal day-night schedule, and so that can be really disruptive and really wear caregivers out. And then as patients progress, they may have difficulty with really basic functions like swallowing. And that's something we see a lot in the hospital, because patients have, even if they're not, you know, frankly choking, and we can see that they're choking, little bits of food particles are getting into the lungs and can set up a pneumonia. We call that an aspiration pneumonia. And that's often what brings advanced dementia patients into the hospital. And so when we see that, we know that's a really clear sign that this patient is in the very end stages, and that's something we can't reverse, and we know it continues to happen and actually get worse.
The
So
body has the ability, an example, a person sound asleep. They can be sound asleep, but the heart keeps beating, the lungs keep pumping, or the lungs keep breathing, and there were what I would call autonomic activities going on in the human body to keep the person alive. Does dementia impair those autonomic abilities?
In most causes of dementia, no. Certainly if you had a more kind of affecting the brain stem functions, which are or what control lung function and heart function, you might. But generally, it's not things like the heart or lungs are not functioning because of the dementia. Often these patients are older, and so they may have heart failure or respiratory diseases that they've developed over the course of their life, but it's not necessarily directly tied to the dementia.
But it's not because the brain has lost its ability to communicate with the heart to keep pumping.
No, because that is,
so to speak.
Nature made it so that that is a very basic brainstem function. So that's why even we see brain dead patients, their heart is still beating because that is the last function to go. And so the body has set it up that way. So yeah, we don't see that.
I think it's fair to say that patients with dementia or of an advanced age develop a debility. You know, they're not as mobile. They don't eat as much with advanced stage dementia. So you become less resilient to fighting off things. You're more prone to complications. I oftentimes think of dementia too as like the magnifier. Because we know that 50% of people who make it to age 85 are going to have some moderate or severe cognitive deficit or dementia. So this is a very common thing that's going to happen to many people. And people don't get to age 85 without having perhaps a few other things. And so in the setting of COPD or heart failure or impaired kidney function, some other chronic illness, you have dementia on top of that. It almost magnifies the ability to have complications from your other chronic conditions. What we know too of people of the same age who fall and break a hip, one with comorbid conditions but not dementia, and the ones that have a similar profile with dementia, the ones with dementia who break a hip and actually get surgery, very high mortality at 6 months, higher than a similar person without dementia who goes through the same process in surgery. So it's a magnifier for if you have dementia as well as other things. It means you're not going to do as well facing the same challenges that other people with similar chronic illnesses will.
So being on the palliative care team, what would you advise when there is a person who's, with dementia, who breaks a hip or whatever, and they're taking a look at what do we do next?
Mm-hmm. So we often
have surgery. What do we do?
We meet with these patients, and more often their families, because often the patients aren't able to make these high-level decisions, and talk about the person's function just before they fell and broke their hip. How were they moving around? How much were they eating? Were they losing weight? What kind of behavioral disturbances might they have had? What was their memory like? And then really talk about what's important to them, that their family can know from who they have been as a person in terms of their mobility, their independence, things like that. And then talk about, as Bridget was saying, what we expect from the surgery. So hip fracture surgery is a really major surgery, and then the recovery process takes a lot of time and also involvement on the patient's part. Patients have to go to inpatient rehab. They're doing a lot of time with physical therapy, and they have to be able to follow the directions of physical therapy and also remember not to get out of bed and try to walk to the bathroom on their freshly operated on hip. And so we talk about, if we feel like a patient might not be able to meet those criteria, that their memory might not be such that they can really follow directions or remember to stay off the hip, that surgery might actually be more harmful than helpful, because someone who has a newly operated on hip and they get out of bed and they maybe fall again, it's only going to make things worse, and they're not going to get that benefit. So families are often really concerned that, they were walking before, maybe not great, and now that if they don't have the surgery, they're not going to walk again. And if patients have really severe dementia, we often say, I'm not so sure that they're going to walk again regardless of whether we do the surgery, because I'm not sure that they can really recover, because their physical body is so debilitated and maybe doesn't have the reserve to bounce back from this major surgery, but also can they follow directions in rehab? Can they, do all the work that's needed to get back to walking with this hip fracture?
So if a person's not going to go for the surgery, how does palliative care help them then?
Yeah, we try to talk about, taking a more comfort-oriented approach, which is what we always talk about in palliative care. What's going to be comfort and quality of life for this patient? So we might say, if you're not going to do surgery, We can manage pain issues. We can manage, other anxiety that might come up in somebody who doesn't really understand what's going on. But maybe take a different approach, focusing more on their comfort, maybe getting hospice involved, and understanding that this hip fracture is a major event in this person's life and is likely to accelerate their decline and bring about end of life quicker than had they not fractured that hip. And we know that hip fractures, as Bridget said, have a high mortality rate, especially in the dementia population, and they can often be a catalyst for, acceleration of progression of disease and end of life.
What type of prevention activities can one participate in to reduce the risk of earlier onset of dementia?
We know that keeping the brain active throughout life is certainly a big piece of that. So I know there's lots of things out there now about like all kinds of brain puzzles and stuff like that, but even just, social interaction throughout life, and certainly as patients get older, keeping their mind active with executive functioning, which is things like paying bills, writing checks, managing bank accounts. So not sort of taking a back seat and just watching TV is not going to kind of stimulate your mind, but reading books, being engaged in volunteer activities, social activities, that kind of thing, learning new things.
And also exercise. Exercise is pretty well known to help maintain cognition. Just anything that you do to maintain health and wellness, but exercise, cognitive activities, staying socially engaged, staying intellectually engaged, those kinds of things.
Does blood flow have anything to do with?
I was just going to say, I would be remiss if I didn't say not smoking is another big piece of dementia prevention. And so that feeds into blood flow, that smoking we know, and diabetes, high cholesterol, these all feed into damaging the small vessels that feed the brain tissue. And so, managing cholesterol, not smoking, and if you do have diabetes, managing your blood sugar all help with that.
When you mentioned exercise, what popped into my head was, let's say, exercise. Exercise is good for cholesterol. Why? Because it gets the blood flowing, and the blood flowing more rapidly cleans the vessels and veins out a little bit. And it is astounding at how well interconnected things are in the workings of the human body.
That's very true.
It truly is an amazing thing to think about. There are so many connections and so many effectual things going on at the same time without anybody giving it any thought. The human body really is a remarkable machine.
Yeah, it is.
And we're always learning more.
Yeah.
That's right.
We've just about run out of time. I just want to thank you so much for coming in. Bob?
My pleasure. Thank you for being a host.
Oh, you're welcome.
Co-host. And thank you very much.
Thank you.
A pleasure meeting you.
Pleasure meeting you.
First time I met you. The others are return guests, and this will not be their last time on the show.
Wonderful.
If I have anything to say about it. And I'd like to think that I have something to say about it. In any event, have yourselves a great day. Thank you very much for being on the show. It was very informative, and Noni, wonderful co-host.
Thanks.
Thank you very
Folks,
much.
To be here.
That's a wrap. Have a great day. Enjoy the weather. Enjoy the coast. Enjoy your life. And be safe. Bye-bye and God bless.